So I'm Deba Leskowitz, and I am a genetic counselor at Christ Hospital. And at Christ Hospital, I work in the Cancer Risk Assessment Program. And we've had a Cancer Risk Assessment Program for probably since 2008, so over 10 years, where we see patients, family histories of cancer, patients who've been diagnosed with cancer, and go through the process of some genetic counseling and genetic testing. So tonight what I wanted to do, if I can just move myself, I guess I can't move myself. What I wanted to do was go over what we do with genetic counseling and genetic testing, sort of give you a run through of what genetics and cancer is, and to talk about some common cancers like breast cancer, colon cancer, so you guys have a sense of the differences between sporadic and hereditary cancer. So we know that all cancer is genetic, but not all cancer is inherited or hereditary. So when we think about cancer, we know most cancer is sporadic. And what that means is cancer happens because of the environment we live in, the lifestyle that we lead. As we get older, our risks for cancer increase. We know that about 1 in 3 people get cancer in their lifetime. And we know that the average age of diagnosis of cancer is in the 60s. So sporadic cancer is about 80% of all cancer. There are familial cancers where we take a family history and we notice that there's a number of people within the family that have cancer. We may have done some genetic testing and not been able to find a genetic cause. So it's probably what we call multifactorial, which means there's genetic and environmental factors that are contributing to the cancer in the family. And that's maybe 15 to 20% of cancer. And then the part that we're interested in and that we spend a lot of time with is the hereditary cancer. But we have to remember that hereditary cancer, or cancers that are inherited, only are about 5 to 10% of all cancers. So who is at high risk for hereditary cancer? That's sort of what we want to talk about tonight. It only accounts for a very small portion of cancer, but if there is a hereditary genetic mutation or a change in a gene that's causing the cancer, that is significant to what kind of screening we do and what kind of risks for cancer that we talk about. So this is just a review, and I don't want to be too technical, but in our human body, we're made up of millions of cells. And in those cells are chromosomes. And the chromosomes actually are the blueprint of the human body. And on the chromosomes are thousands of genes. And so we have genes for hair color and eye color and how tall we're going to be and how we're going to digest our food. And we have genes to protect us from cancer. And so those are the genes that we want to look at when we're thinking of hereditary cancer. The bottom picture here sort of shows that in a little bit of a diagram where if you were to sort of unwrap a chromosome, you could find on the chromosome a gene, and then that gene makes a protein in our body. So all cancer comes from genetic mutations, but all cancer, as I said, is not hereditary. So I don't know if my picture is covering this or not, Ross. Are you guys able to see that, the picture? So in this picture, it sort of is divided into somatic mutations and germline mutations. And what that means is somatic mutations are genetic mutations that you only find in the tumor. So if somebody had breast cancer and we took some tissue from that tumor of the breast, we would find mutations because mutations cause abnormal cell growth. So we would find mutations in that tumor, but we wouldn't find mutations anywhere else. We wouldn't find it in the person's skin or their blood or their hair or any of their organs, because that type of genetic mutation is not inherited, and that's what we call sporadic cancer. But germline mutations are mutations that are present in the egg and the sperm. So when somebody is conceived, those mutations can be passed on in the egg or in the sperm, and that's why they're called inherited. So the picture on the right-hand side shows you that a person could have a mutation in her egg and she could pass it on to her child, and then every cell of that person would have that mutation. So of course, there are very many factors that affect the penetrance of the gene. What's the likelihood of us getting cancer? And so, you know, as a lot of people know, there are carcinogens. As an example, someone who smokes has a higher risk for cancers than somebody who doesn't smoke, because they're bringing carcinogens into their body, and those carcinogens could cause mutations that could lead to cancer. So importantly, we know that not everybody who has a mutation actually gets cancer. If you have a genetic mutation that's inherited, your risk is much higher to have contract or to get cancer, but it's not 100%. And so this is sort of how it works. Remember I said that genes come in pairs, or that we get half of our genes from our mom and half of our genes from our dad. When we're thinking about a cancer and we're thinking about a cancer gene, in the top part, when you're developing sporadic cancer, let's call the gene that we're looking at X. So you get a gene X from your mom and a gene X from your dad when you're born, and they're working fine. And if you go through the arrow to the second genes, you can see one gene is working, and then you see a non-working gene. You see a gene that got mutated. There's a red line through it. So somewhere along the line, this gene got turned off by some environmental or lifestyle component. But this person doesn't get cancer because they still have a gene that's working fine. And then maybe when they're 60 years old or older, that second gene turns off. So a person in sporadic cancer starts out with two genes. Say we call these two gene X's, one from their dad, one from their mom. Through their lifetime, these genes mutate or turn off, and then a tumor develops. So typically sporadic cancer happens later in life because it takes two mutations in order for the cancer to develop. Below is how we get inherited cancer, or the way inherited cancer happens. And that means that when you're born with a gene that's working fine, and you're also born with a gene that's mutated or turned off. So you already start with one gene that's not working properly. And then maybe in your 30s or your 40s, that second gene turns off, and then you get cancer. So it's the same kind of pathway, except when you start off with one gene that's mutated or not working. So typically people who have an inherited cancer get cancer earlier in life. So most hereditary cancers are inherited in what we call an Autosomal Dominant pattern. So the picture on the left shows you that the dad has a mutation in a gene, and he has the increased risk for, let's just say, pancreas cancer. And the mom has two genes that are working fine, and she doesn't have an increased risk for pancreas cancer. So the check is the working gene, and the X is the non-working gene. So the father has a working gene and a non-working gene, and the mom has two working genes. And then below you can see what the kinds or the types of kids they could have. They could have children that don't have the condition, that they both have genes that are working fine from both parents, or they could have children that have the condition where the father's passed on the gene that's not working. So the bottom line for this is, when you carry an inherited cancer gene, you have a 50% chance to pass it on to your children and a 50% chance not to. the picture on the right shows you what we call a pedigree, which is a diagram of families where circles are female and squares are male. And this can show you the green circle is the person that has a woman that has ovarian cancer, and the purple circles are the women that have breast cancer, and the squares or the circles that have the dot, the purple dot in one, are the people that have a mutation, but they're unaffected right now. So as an example, all the way over on the left is a woman who has breast cancer, and her father carried that mutation and passed it on to her, but he's unaffected with the condition. So this is just sort of to give you an idea of, you know, how we look at family members and how we figure out what risk is when there's a mutation within the family. And I'll certainly go into that in a little bit more detail later. So the really question that people have for us is, what is my risk for cancer? So the most important thing that we have, the most important tool that we have besides genetic testing, is a family history. So it helps us with accurate risk assessment, it helps us with genetic counseling, and it also helps us with surveillance and medical follow-up. And so one of the most important things to do is to try to gather your medical family history from people before they pass on, like your parents or your grandparents. And this is sort of what we do first off when we talk with patients, is we get what we call a pedigree. So it's a 3-generation family history. We want to know the ethnicity of the family and the race of the family. We want to know the age of onset of the cancer, because remember I said the earlier diagnosis of cancer, the greater likelihood, or an earlier diagnosis is sort of a red flag to us that there may be an inherited component to the cancer. We like the age of onset and the cause of death. We like to know if the cancer is metastatic. So in other words, if somebody says, well, I had brain cancer, or my cousin had brain cancer, well, was that the first cancer, or did your cousin have maybe breast cancer that metastasized to the brain? We want to know if there's multiple cancers, if they're bilateral. We want to know if there's any surgeries. The picture that you see here, the squares are males again, and the colored in squares are people that are affected. The circles are females. And if you have a line from a male to a female, that's a marriage. And then if you have lines through people, that means that they're no longer living. So this is what we do as genetic counselors for every family, so we can sort of get a picture of what's going on in the family to see if there's a pattern of inheritance, and just to see what cancers are in the family, and if they go together, and the ages, sort of give us a sense of what's happening. So when we take the family history, we can sort of break the families down into 3 different sort of risks. We have people that sort of have an average risk, because we know that if you take a family history, you're going to have cancer within the family. So, you know, we do take the family history and say we find a grandmother that had breast cancer at 65, but there's no other family history of cancer, then likely that's just an average risk person for breast cancer. There's moderate risks where there's a familial sort of, we see cancer more than we would expect in the family, but we can't pinpoint a particular genetic mutation. And so that's sort of, we personalize the screening based on the family history. So we may be able to give them risks, if we're talking about breast cancer, we may be able to give them a risk that's higher than the general populations where we would want to do additional screening. So maybe they have 20% risk for breast cancer, and so we would recommend mammograms and MRIs every year as opposed to just mammograms. And then we have our high risk group, which are people that are very high risk. They have a genetic mutation. They need to have particular management based on the mutation that we found, as well as for surveillance, and other family members need to be made aware of the mutation. So compared to sporadic cancer, people with hereditary cancer have a higher risk for developing cancer, usually at a younger age. Generally, we see cancers under age 50. People who have a hereditary cancer can have multiple primary cancers, and these cancers are more severe and the disease is more accelerated. But remember that inherited cancer is less common in the general population than sporadic cancer. Again, only about 5 to 10% of cancer is inherited or hereditary. So I wanted to go over sort of breast cancer genes and colon cancer genes because they're the most common mutations or the most common inherited cancer syndromes that people are aware of. But I just wanted to show this picture to say there's a lot of genes associated with different cancers. So we're learning more and more, and these boxes are getting bigger and bigger. So, you know, back in the 1990s, we only knew of a couple genes associated with breast cancer, and now there's many, many more. In fact, the genes for cancer really weren't found until the mid-1990s. So a lot of these genes are very newly found genes. So when should we expect an inherited cancer syndrome? If there's 2 or more close relatives with cancer. The most important thing is the early age of diagnosis. So anybody diagnosed with cancer under 50, that's a red flag to us. If you have more than one type of cancer, say you had breast cancer and then you had ovarian cancer, or you had colon cancer and you had endometrial cancer. If you have a rare cancer like pancreas cancer or ovarian cancer, and we do know that some tumors go together, like as an example, colon and endometrial cancer go together. And then if we look at your family tree and we see cancer in the grandparents' generation, in the parents' generation, in the patient's generation, then that's sort of as suspect to us. I'm going to go into breast cancer a little bit first. And this is just a diagram to show you that, again, most cancer is sporadic. There's a small piece, which is the gray piece of the pie, that is the inherited component. Same with ovarian cancer, a little bit higher inherited component with ovarian cancer. Still, the great majority of breast and ovarian cancer is sporadic. These are the most common hereditary breast cancer syndromes. HBOC is probably the one that people know of most, and some people know of it as the BRCA genes, or BRCA1 and BRCA2. They were the first genes that were found when we were looking for cancer genes. These other syndromes like Cowden syndrome, Li-Fraumeni, Peutz-Jeghers, probably not things that people are aware of, but they are also associated with breast cancer. And then you can see that each syndrome has a particular gene associated with it, and also particular cancers. So the hereditary breast and ovarian cancer syndrome has breast, ovarian, prostate, pancreas, melanoma, sometimes stomach. And so some people think of BRCA or BRCA genes and they think only of females, but we have to realize that some of these cancers that we find in the HBOC are associated with males as well. So the BRCA1 and 2 genes were the first genes discovered that are associated with cancer, and they were discovered in 94 and 95, so not that long ago. In fact, when I graduated from my master's program in genetics, we didn't think there were any genes associated with cancer. So that tells you that I've been around for a while, but it also says that it's fairly new in discovering things. And it's sort of opened the door to cancer genetic counseling. And if you look at the picture, that's a picture of chromosomes, and you can see they come in pairs. So there's 23 pairs, and the BRCA1 gene is on chromosome 17, and the BRCA2 gene is on chromosome 13. So there are some myths related to BRCA1 and BRCA2, and one of the most common ones that I just mentioned was that you can only inherit the gene from your mother. Many people think, well, it's breast and ovarian cancer mostly, so I would only be worried about my mom's side of the family, but not true. Males can carry that mutation and pass it on to their children. And so If there's family history on the father's side of breast and ovarian cancer, that's still a concern. And we are very concerned when we see ovarian cancer. That's a very important indicator. It's not just breast cancer. And it's most important to look at the age of onset. So I'm much more concerned if I'm talking to a person who is like 32 years old with breast cancer that doesn't have a lot of other family members with cancer than I am with a 65-year-old woman with breast cancer who maybe has a 95-year-old mom with breast cancer. So the BRCA1 and 2 genes are found in about 1 in 800 women, so they're not uncommon. About 16% of women with breast cancer under 50 and a close relative have a mutation. We do find it more commonly in the Ashkenazi Jewish population, and that's why we do ask about ethnicity. We know that there are particular mutations within different populations called founder mutations that are more common. 25% of all Ashkenazi Jewish women with ovarian cancer have a mutation in BRCA1 or 2. This is a pedigree, a picture of someone's family, and I'll walk you through it. The circle that's blue with the arrow is a 36-year-old woman who is coming to talk with us about her family history. She has a sister who is 36 now, but at 34 and then again at 36, she was diagnosed with breast cancer. If you follow up, you can see her mom and her dad, and her mom has a sister who had breast cancer and then had ovarian cancer and passed away. If you follow that up to the patient's grandmother, she was diagnosed with breast cancer. This is a typical pedigree or typical family that we would expect to have a BRCA1 or a BRCA2 mutation. Young age of onset of cancers and breast and ovarian cancer in a family. This is a graph to sort of give you a sense. If you carry a BRCA1 or 2 mutation, your risks for cancer are much more significant. So BRCA1 and 2, the risk for breast cancer in your lifetime could be up to 85%. Now, the important thing to know is it's not 100%. So that's why you can see in families, members that don't have cancer, that have children with cancer. They could carry the mutation, but they haven't been affected with cancer. There's an ovarian cancer risk, which is much higher than the general population. And then male breast cancer is higher, though small, certainly higher than the general population. And prostate cancer is a little bit higher as well. This is just another way to look at it. Breast cancer, early age of onset, 50 to 85%, a second primary breast cancer higher, and ovarian cancer. We do know now that there is a risk for pancreas. Colon cancers on the fence, there's been a study to say there is, but there haven't been any other studies that have suggested that there's a higher risk for colon cancers. And here are the cancers of risk to men that have a BRCA mutation. So this is why the myth of worrying about, you know, the maternal side of the family and not the paternal side of the family is untrue. So what do you do if you have a mutation like in BRCA1 or 2? Remember, you were born with it, so it's in all your cells of your body. We can't change it. We can't fix those cells right at this time. We can't fix that mutation. Maybe, you know, in years to come or decades to come, they'll figure something out. But right now, it only provides us information for prevention and screening. So people who have a mutation in BRCA1 or 2 have mammograms and MRIs every year. They may think about having prophylactic mastectomy. So they may decide to have both their breasts removed, even without having breast cancer, to lower their risk to get breast cancer. They may consider taking medications to reduce their risk. For ovarian cancer, we really don't have any good screening tools like we have for mammograms and MRIs for breast cancer. So the screening could consist of doing CA-125 or transvaginal ultrasounds. Again, not perfect. We do say people can go on birth control pills to reduce their risk, but really when you're done with childbearing and you're close to menopause, we suggest to have your ovaries removed and your fallopian tubes so that you lower your risk as much as possible for ovarian cancer. And then you can see the other cancers there and what we would do as far as prostate, pancreas, and melanoma. So this is an important slide because when we do genetic testing, it's important to pick the right individual to do the testing. So on the left-hand side, it says no identified mutation in the family. So the patient is the arrow is a 37-year-old woman whose mom had breast cancer at 41, and she has a maternal aunt had breast cancer at 35. And the patient coming to me is 35, and she's 37 with no cancer, and she tests negative. However, we don't know, does her mom have just sporadic breast cancer, or is the family have breast cancer for another reason and that patient is still at higher risk? Or does the mom have breast cancer and there is a mutation and the patient doesn't have it, so she comes close to the general population risk? So this is sort of inconclusive, and I would have to follow this patient to say, I don't know why your mom had breast cancer, so you're still at risk. You're at a higher risk than the general population because you have a mom and an aunt with breast cancer. However, if I test the mom on the right-hand side and she has a mutation, then this patient is truly negative. So we know the breast cancer is because of a BRCA mutation, and the patient didn't get it. So she is very close to the general population risk for breast cancer and does her mammograms every year. Whereas the patient on the left, we don't know. So we're probably going to do increased screening because we don't have the answer as to why the breast cancer occurred. So typically we like to test somebody who is affected with cancer and the person that is the youngest in the family that has a cancer diagnosis, because they have the greatest likelihood to carry the mutation. So that was breast cancer. I'm going to go on to colon cancer, and then we'll talk a little bit about testing. So again, same kind of thing. Most colon cancer is sporadic. There are a few genetic syndromes that are associated with colon cancer. 5 to 10% or so of colon cancer is inherited. And so you can see that below here, there's a condition called Lynch syndrome, which I'm going to go into, and then this other condition called familial adenomatous polyposis, which is just sort of a garble of what we call a lot of polyps, and I'll call it FAP. So when we sort of look at hereditary colon cancer, we think of cancer conditions that have lots of polyps and colon cancer conditions that have very few polyps. So when you look at lots of polyps, there's a couple different inherited syndromes that we know of. I'm going to talk about the FAP. That's the most common. And then when you don't see very many polyps with colon cancer, you think of one of the most common inherited cancer syndromes, which is called Lynch syndrome. So colon cancer non-polyposis, or colon cancer genes that aren't associated with polyps. The most common ones are the ones at the first box, and those are the ones associated with Lynch syndrome. Lynch syndrome is just based on the person that found those genes, Henry Lynch. And so you can see if you have a mutation in any of those genes, you have a risk for colon, but other cancers as well. The rest of these genes aren't really as common, but we do see like TP53, and you can see that this genetic inherited cancer syndrome is associated with a lot of different cancers, including breast cancer. CDH1, again, breast cancer is common in that with colon. So we're taking family histories, and so if we see someone who comes for breast cancer, but we also see colon cancer within the family, that can be concerning to us as well. So this is a pedigree of somebody's family who has Lynch syndrome. And Jane is 26. She's the person that comes to see us. And Kevin is her father, who's fine. And then you see on Kevin's side of the family, Kevin has a brother, Steve, who had kidney cancer, a brother, Bob, who had colon cancer, sister, Mary, who had endometrial and colon cancer. And we sort of do different hashtags for different cancers so we know what cancer we're thinking about. And then Jane has first cousin Christy, who has colon cancer, GINA, who has endometrial, Linda, who has colon. You can see these are young age of onset. So this is a concern. This pedigree would, I would be wondering if there was a mutation in a gene for Lynch syndrome based on the cancers that I see on the father's side. Now, the mom had breast cancer at 66, but there's nothing else on that side of the family. So likely Paula, her mom, just has a sporadic breast cancer. So this sort of gives you an idea of what your risk is to have Lynch syndrome or have a mutation in any of those genes up to age 70 compared to the general population. So as an example, colon cancer, the general population risk is about 70% or 7%, excuse me. But the risk if you have a Lynch syndrome gene is between 70 and 80%. And the mean age of onset, in other words, when does a cancer usually arise? 45 years of age. So you can see the risk is significantly increased if you carry a mutation versus the general population. And you can walk and see each one is a little bit higher, but colon, endometrial, stomach, ovarian are the most common ones, and they have those highest risks. So if you have a mutation in a gene and you have Lynch syndrome, you have anywhere between a 16 and a 30% chance for a second primary colon cancer in 10 years of your first diagnosis. So it's much more common to have recurrences. NCCN are national guidelines, and they do differ if a patient has colon cancer and Lynch syndrome or colon cancer without Lynch syndrome. So one of the most important things is colonoscopy. So that's our screening tool for colon cancer. And we know that if you have Lynch syndrome, you have colonoscopies every 1 to 2 years for the rest of your life. But if you've had colon cancer and you didn't have a Lynch syndrome mutation, you would start out having colonoscopies more regularly. And then slowly but surely they would the interval would be longer and longer based on the findings of your colonoscopy. And then if you have Lynch syndrome, you have risks for other cancers, like we mentioned, endometrial or ovarian. And you don't have that if you have a sporadic colon cancer that's not associated with an inherited mutation. And there are also some changes in surgical management based on whether you have a mutation or not. This is sort of the rationale for frequent colonoscopies. We know that in the general population, a polyp can go from just a polyp to cancer in about 5 to 10 years. But we know people who have Lynch syndrome, their progression from a polyp to cancer is much faster, maybe 1 to 3 years. So that's why we want to have colonoscopies much more frequently, because if we take the polyps out, the person isn't going to get cancer. But if the polyps stay in, then they can turn into cancer. So that's sort of the Lynch syndrome, which is the most common colon cancer associated with no polyps. And then these are the genes that are associated with a lot of polyps, or what we call polyposis. And the most common one is that APC gene associated with FAP, the familial adenomatous polyposis. And these are people who have hundreds to thousands of colon polyps. And their risk to get colon cancer in their lifetime is almost 100%. And then these are other genes that are also associated with colon cancer and polyps. So FAP and MAP are sort of the most common polyp colon cancers. And that's a picture on the right-hand side of what polyps look like. And again, these polyps happen earlier in life. We can also have other cancers. This is a condition where we do test minors. Typically, genetic testing is done only in adults, but with FAP, you can start seeing polyps at 10 to 12 years of age, so we do it earlier. So as I mentioned, the risk for colon cancer can be up to 100%. There's other cancers also associated with FAP, but not as common. This just gives you a sense of different surgeries and surveillance guidelines that we use based on what kind of mutation that we found. Sometimes, colonoscopies are done early, sometimes they're done in the pre-teens, sometimes they're repeated every 1 to 3 years. This just gives you an idea of, if you have a mutation, we have good surveillance guidelines so we can watch you closely. And this gives you an idea of just sort of empiric risks for people. You don't have a mutation. There hasn't been a mutation that's been found in the family, but you may have an increased risk for colon cancer anyway. So people who have no family history have about a 4% risk for colon cancer. If you have a first-degree relative, so say you have a sister or a brother or a child or a parent with cancer, then you have about a 9% chance. If you have a first-degree relative or more than one first-degree relative with colon cancer, your risk is up to 16%. So family history is important in trying to find what your risk is and what your next, how you should be managed. So in the world of cancer genetics, I was just talking about germline testing, or testing that's done, on saliva or blood, but we do now testing on the tumor, and it's a little bit different, but it does help physicians make decisions about treatment. So in talking about genetic testing, we really, before about 2013, didn't have a good, a lot available to patients. There was the BRCA1 and the BRCA2 gene, but those genes were patented by a genetic testing company called Myriad. And so it actually had to go all the way to the Supreme Court for them to say you can't patent genes. And so then once that happened, the floodgates sort of opened with other laboratories doing genetic testing, and other labs were doing research on a lot of other genes. And so that really gave the consumer the availability to get testing. It wasn't as expensive. It used to be maybe $6,000 to get testing. And now, we can do panels of genes, 80 genes for $250. So when one of the main things that people remember is the Angelina effect, because Angelina Jolie found out that she carried a BRCA mutation, and she decided to have a double mastectomy, and she also had her ovaries out. And since she is, well known, that sort of made people stand up and sort of think about genetics. This is sort of the timeline of how we've been doing genetic testing. So BRCA1 and 2 were first, and now we got some different ways to look at genes, so we could do it more faster and cheaper. And the first oncology panel of genes, more than just 1 or 2, was in 2010. And now we have, panels of 80, 100, 120 genes. So genetic testing isn't a screening test. It's not for the general population. It may be in the future. It may be something where it's so cheap that everybody has it done. But right now, all insurance companies don't cover everybody without a reason. So it is one thing that we do to try to help patients through their journey. These are just different types of genetic testing. We can do single site testing if we know what the mutation is in the family, but typically in cancer, we do panel tests. But we could look at all your DNA in your whole gene, what we call genome. We don't typically do that in cancer. It's more done maybe in pediatrics, where they're trying to look for a reason for a child who has, some developmental concerns and also some physical handicaps. So tumor testing is done, and if anyone's had cancer, they know sometimes they do what's called an oncotype, or they do a mammoprint, or they're actually looking at a piece of tissue, and they're trying to help diagnose the kind of cancer and what kind of treatment. Different mutations have different treatment options. People do testing to find out what mutation they have, and then they may have a certain chemotherapy that works for them because of that versus a chemotherapy that won't work because they don't have a particular mutation. The panels that we use are called next generation sequencing. So it's an automated system. And because of that, we can do many, many genes all at once. And so there's a lot of different panels. There's singular panels like for breast, colon, ovarian. And then there's panels that are sort of all encompassing. And this slide is even old now because there's more than 81 genes on panels now. There are actually some panels that may have 150 genes, and they're actually simultaneously and now analyzing all the genes at the same time. And the price is usually between $1,500 and $2,000, but there are a lot of laboratories that will give a self-pay price, and that's usually much less, like $250. And most insurance companies, including Medicare and Medicaid, cover testing if you meet particular guidelines. So the reason that panels are so good is because they're cost efficient and you can have a comprehensive approach. So you might have a family that looks like BRCA1 and 2, but they have a gene in another, or they have a mutation in another gene that is still associated with breast cancer. The cons are that not everybody needs a panel. Sometimes people have panels when they already know that there's a mutation within the family. And some of these genes that are new on panels, we don't have really good guidelines because we don't have enough information because we have limited data. Of course, the more patients that have the testing, the more information that we have. The results when we do a genetic test are the following. You could be positive, which means you have a mutation. We've identified the genetic mutation, a change in a gene. One of your genes is turned off, and now you have a higher risk for cancer. And we need to talk about screening and medical management. Or it's negative. We didn't find a mutation in any of those genes. Your family looks to be maybe a familial family. Maybe in the future there'll be something that we find, but right now we don't see anything to indicate to test other family members, and you don't have an inherited concern. Sometimes we see what are called variants of unknown significance, and that's that we find a change in a gene, but the laboratory hasn't seen it enough to be able to classify it as a benign finding or associated with inherited concern. And so we just have to wait for them to see it more often before they classify it. We call this negative because the greatest majority, over 95%, are found to be negative maybe within 6 months to a year, and we get an amended report. But sometimes that's a concern for people who don't know what a variant of unknown significance is. I'm going to pass through that. Again, the cost used to be very high. It used to be maybe $1,000 a gene, but now it's much less. And a lot of the laboratories offer pre-verification, so you know how much out-of-pocket you'll have to pay. So it's very streamlined now, and most people who want genetic testing will have it covered. We do have a federal law called the Genetic Information Non-Discrimination Act. We call it GINA. And that's a federal law that protects against discrimination based on genetic information. Some people are worried that their information is going to get out there and they're not going to be able to get health insurance or life insurance. And this covers any genetic information, a predictive test, a family member's genetic test, or just your family history. It protects you in group and individual health insurances. They can't drop you, or it's not a pre-existing condition where you have to pay more premium. And it also protects you for employment. They can't, they can't fire you. It doesn't cover the following, like life, disability, long-term care. They weren't able to get all that in when they had the bill signed, but the bill was signed, long time ago, 12 years ago. So I just want to quickly go through genetic counseling, because genetic counseling are really the professionals that work through all this with families, and they have the expertise, because genetic counselors have master's degrees in genetics, medical genetics, and they're certified and they are licensed. And so they're sort of the experts in this field. And they do a number of different things. So they explore family histories and they identify risks. They offer support and they identify resources to patients. They can discuss the disease and the inheritance and review the testing options and help patients make decisions about whether they want to have testing and then decisions about what they're going to do with that information. They educate communities like I'm trying to do tonight. And they also help with testing of other family members if a mutation is found. We call that cascade testing. We typically review a family history. We discuss your personal risks based on your family history. We go through basically things that I've talked about tonight about the availability of genetic testing, the risks and benefits of that, what screening tests and medical management we might do, and then of course referrals and support to other support services just like Gilda's Club. Of course, there are issues, counseling issues associated with genetic testing. So, you know, it's scary sometimes to think that you have a genetic mutation. If you are, you know, a person who has a family, you have worry or guilt that you might have passed it on to your children. You feel, you know, sort of there's a change in family dynamics. You may have a mutation and your sister didn't get it. And you might be a little bit jealous of that, or your sister that didn't get it is feels bad that you carried the mutation. So there's all kinds of, you know, family dynamics that go into this genetic testing. And then there's also some ethical issues. So, you know, once you find out that you have a mutation, your brothers and sisters, your children, your parents, they all have a 50% chance. And then you can go even farther to aunts, uncles, cousins. And, you know, what is our duty to give them that information so that they can be proactive with their health if they'd like to be. And then, you know, the worry that some people have of discrimination, not necessarily in insurance and employment really, but maybe social discrimination or people looking at you differently because you carry a mutation in a gene that causes you to have a higher risk for cancer. You know, there are limitations. Obviously, we can find out that you have a higher risk for cancer, but we're not going to be able to prevent it unless we do screenings, and those screenings aren't always 100%. And a negative result tells me that you don't have a higher risk, but you still have a risk. Everyone in the general population has a risk for cancer. And right now we can't identify all the causes of hereditary cancer. You know, every year we come up with more genes that are associated with cancer. And if you have a, you know, if you aren't affected with cancer and you have a mutation in a gene, that can really increase your anxiety because you're like, well, when am I going to get it? What's going to happen? You know, every time I go to have my mammogram, are they going to find something? So it does take a toll on people as well when they find out, even if they don't have cancer. So, you know, why is knowing this information it's important? Why is knowing this information important? Excuse me, because of prevention. Because we can do increased cancer surveillance, so we can tailor your health management. We can tailor the chemotherapy if you need chemotherapy. We can do risk-reducing surgeries. So if you have a risk for ovarian cancer, we can you can have your ovaries and fallopian tubes removed. We can detect it early. We can let family members know so that they're prepared. We can relieve uncertainty and anxiety. Some people tell me, oh my gosh, I just knew I was going to get it. I just didn't know when, you know, because my sister had it, my mom had it, my aunt had it. And if we find a mutation in the family and that person doesn't carry it, then what they've always thought isn't true. And that's even hard to take because they're sort of basing their life on the fact that they were always going to get cancer. And then I'm telling them, well, it's not that you're never going to get it, but you don't have those risks because you don't have that mutation that's in your family. So there are a lot of complexities to genetics. It's important to look at the family history. It's important to know who to test and what we should be testing. The results are complicated in some respects because of that variance of uncertain significance. and also what the medical management is based on the mutation. Each mutation has different risks. And then what do we do with other family members and their risks? And so this is sort of the top 10 reasons to know your family history. So free medical screening done in the privacy of your home. Number 9, great way to get to know your relatives. Number 8, good way to know your risks for conditions in your relatives. Number 7, when you need to know, they may not be there to ask. Number 6, with a little help from the past, you can change your future. Number 5, not just recipes that get passed down in families. Number 4, a priceless gift you can give your children. Number 3, doesn't cost a thing and could save your life. Number 2, what you don't know can hurt you. Number 1, every family has a story, but not every family has your story. So with that, I think I'm done. Does anybody have any questions?
Thanks, Deb. That's a great amount of information. Yeah, definitely. Let's open it up to any questions. I know that looks like Victoria had one in the chat. So she said somatic, and then I think if this is kind of at the beginning, somatic, what they test for with the oncotype. Victoria, I don't know if you want to clarify, or you can unmute yourself.
Yeah, I was just assuming that the genes that they test for when you get the oncotype test, that's was the somatic type, right?
Right. When they're testing for the oncotype, they're looking at the tissue of the tumor to see what the mutations are in the tumor, and that might help them with treatment or a plan for your management. But that's not a germline or an inherited. And a lot of times now there are laboratories that are doing both at the same time, so people can get the inherited gene mutation test as well as the somatic.
Anyone have any other questions?
Yeah, hi Deb, my name's Karen. I was just wondering, is there any genetic testing available for lung cancer, specifically non-small cell?
Right, so there's been a lot of, are you there?
Yes, yes.
Okay, I'm sorry, so we don't know as much about lung cancer, but that's really coming to fruition now. We have a couple different genes that are associated with lung cancer, but most of the time, the great majority of the time, it's an environmental or a lifestyle. We typically don't test for lung cancer unless we see a strong family history, and there are some research teams out there looking at the genes associated with lung cancer, but that's just another place where we really need to put our efforts because we don't know as much as we should probably about lung cancer.
Which is kind of surprising because that's like the #1 cancer. Right. And so, right. And it's.
But we do know, I mean, we do know like with lung cancer, as well as some other cancers, a lot of it environmental. Remember, only 5 to 10% of cancer is inherited, and lung cancer can be, you know, firefighters, can be like if you work in a coal mine, or if you're exposed to any kind of, you know, maybe you're a smoker, or you're, you know, other kinds of influences that are environmental, we believe are mostly the causes of lung cancer. But when you see families where there's lung cancer in generation after generation and their young age of onset, there has to be some genetic component to it, but we don't have it all sorted out yet.
Yeah, and I know it's like in my family, I mean, that wasn't the case, unfortunately, and it was very rare, very unpredictable. We don't know where it came from. Mm-hmm. With my mom. And I remember talking to also our internist, and she said that even for prevention, I mean, most that they have, she didn't go into genetic testing, but she kind of went into, you know, low dose CT scans and things like that.
Right.
But
yeah,
long term, the effects of that can do more harm than not. And it's just kind of frustrating too, because, you know, given like my mom's history, I mean, there was no warning, and it was just so quickly how it evolved to the stages into stage 4. I mean, literally like within a month, and
wow,
no sign of anything, and it was a really difficult journey. And so, you know, and I had gone to a couple of the the lung cancer conferences, research conferences, and they're always talking about, you know, preventative measures, which of course is great, but they only had for small cell.
Yeah.
And at the same time, it's just one of those things where it feels like it's so catch-22, that particular cancer. So,
you know, and I have heard, in fact, I have a personal experience with a friend of mine who has non-small cell lung cancer, and they did testing on the tumor, and that was helpful because they found something that they could, chemotherapy-wise, give her. She had a particular mutation that was in a specific ethnic population. And so when they did that testing, then they saw that there was, you know, some research opportunities and some drugs out there. So like I always tell patients who have rare cancers or things that we can't look at inherited wise, you know, doing that somatic testing of the tissue is really helpful. And medical oncologists are more and more using that for treatment guidelines.
thank you.
Great info. Thank you. Anyone else?
I do.
I had a, oh, sorry.
Go ahead. Go ahead.
Laura, why don't you go and then we'll go with Victoria after that.
Okay, thank you. So I thought I knew my question until I heard what you said a few minutes ago. So my cancer's uterine and everything came out and they did testing and some of the things that I didn't know what they meant until tonight, the P10 and MSH this and blah, 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 blah. And I recently asked again, I don't have children, but I have 2 nieces and a sister. Nobody that we know of in my family, just me, ever had cancer. So according to my doctor, is this correct? So I asked the question, what is the concern for my nieces and my sister of getting uterine cancer? And based on all those things testing negative or however the results of those things come out, I don't know if it's a number or just negative positive, but for those genes that know that they do not consider and since nobody ever had it in my family, they do not consider this a hereditary risk for my sister or her daughters. You said something a few minutes ago about when they test for that, they're testing more for the patient, like on how to, that might be helpful information for chemo, etc.
So let me ask you 2 questions before I answer yours. How old were you when you had your diagnosis?
56.
And what testing did you have done?
Well, it was all tumor and they said abdominal fluids testing. It wasn't testing I ever asked for. It was all done along with or after the surgery.
Mm-hmm. So you probably had somatic testing on the tumor, and you probably didn't have genetic testing, so to see whether you had a mutation or not. Typically, if there's no family history and somebody has uterine cancer, they do testing on the tissue, and some of the testing, without getting into specifics, you know, and confusing you, some of the testing that they do on the tumor can point to whether it's more likely a sporadic cancer or it might be inherited and you need additional testing. So usually, I mean, through Christ Hospital, we automatically test all uterine cancer and colon cancer for the proteins that are made by those Lynch syndrome genes.
Yes.
And if they come back, if that comes back normal, then the greatest likelihood is the person has sporadic cancer unless they're under 50 or they have a significant family history. So if you had that testing and it was negative, and then you had, and you're the only person and you're over 50, then the likelihood is remote that there is an inherited component, and much more likely that it's sporadic. And if that's the case, then it's not that, it's not a big concern for your sister and her children.
Can I ask one more question?
Yeah.
So obviously long ago, I had a friend who died of lymphoma at age 21.
Mm-hmm.
Being so young, that would tend to tell us, looking in retrospect, that that was more likely hereditary?
So that is concerning because that person was very young, but the family history is important as well. And again, lymphoma is hard because that's another cancer that we don't know a lot about, lymphomas, leukemias. But somebody 21 with a lymphoma is a red flag. And if there was a patient that had a lymphoma 21 here now, they definitely should be referred for consultation and testing.
Thank you.
Yeah.
Victoria, did you still have a question?
Yeah, my question was, I had genetic testing done through Christ Hospital, and I was wondering, is there any, like, do you guys have like a newsletter or anything where you send out updates to people regarding any good research that comes out regarding people with bad genes, so to speak?
With bad genes, is that what you said?
Yeah.
So do you carry a mutation in a gene?
Yeah, I have the BRCA2.
Mm-hmm. And are you being followed with your physicians or?
Oh yeah, I have everything through Little Company of Mary because of my insurance, but I had the genetic testing done through Christ, and it came back that I had the gene. I had breast cancer, and then I had my ovaries removed.
So I would suggest to you to go online. I mean, we don't send anything out. We always tell patients, contact us. And if you saw a genetic counselor through us, we try to reach out every couple years if there's anything new and send something out. But there's a very good support website, as well as really strong group called FORCE, Facing Our Risk of Cancer Empowered, FORCE. I don't know if you ever got any information on that. It's a great website and it gives all kinds of research opportunities and all the new data of what's going on as far as treatment, as well as blogs to talk to people who are going through the same thing that you've gone through, and the surgery. It's just a wealth of information, and it's a really good place to start and really get the information that's up to date.
And Deb, what was that website again?
It's FORCE, Facing Our Risk of Cancer Empowered. So FORCE.com, I think. But if you saw one of us, you probably got some of that information, did you not, Victoria?
Yeah, I got it. I check out FORCE. I was just wondering if you guys did any sort of newsletter from,
Yeah,
Christ.
we haven't been able to do that yet. No. That's a good idea. We used to, yeah, I'll just say that. It's a really good idea.
Deb, we have a question. Is there a way that someone can reach out to you privately to ask you questions?
Sure. You can just call my office line. Do you want me to give the phone number?
Yeah, you can either do that, or I was just going to write it in the chat room, whatever, or the chat box, whatever works.
Okay, the number is 708-684-3373.
Okay.
And that's the Cancer Risk Assessment program at Christ. We're on the 8th floor of the outpatient pavilion. And there's 3 of us. There's myself, Christina Ruiz, and Jason Murphy, and any of us can answer any question. But if you call and you want to just talk to me, it gives you a prompt. I think I'm number 3, and then you can leave a message.
All right, that is in the chat box. Thank you for that. And for the record, I've worked with all 3 of them, and they're all wonderful people. Just thought I'd throw in that plug for you.
Thanks. You couldn't say anything but that.
Other questions? Anyone else have anything?
Just one other quick follow-up question. So in terms of genetic testing with comorbidities like heart disease, how does that work? Or is it just completely separate and you'd have to go to like your cardiovascular or cardiologist just for that separate piece of family history?
Right, so we only do cancer, and genetic counselors are pretty specialized now because like you just said, there are panels for cardiovascular disease, and there's panels for pediatric and prenatal and neurology. And so you know, whereas maybe before we were sort of versed in a couple things because there was only prenatal and pediatric. Now, you know, there's pharmacogenetics and there's psychological, and so there's a ton of different ones, and I can't know everything, but there are genetic counselors within Christ that do adult, and they would do they work with cardiologists, and they do you know, run cardiology panels of, you know, 20 different genes. So that's where I would go with that, because we would only do cancer genes. We wouldn't cross over to cardiovascular genes.
And if that's the case, though, I mean, is there one that takes, in terms of preventative care, is there one that takes priority than the other? I mean, it seems really tricky, but I'm just curious if there's been any kind of trends or what's kind of like the positioning on that?
Well, I don't know if I understand your question. I mean, if you have a strong family history of cardiovascular events and you're at risk, then that's important to know so that you can know whether you have mutations that would cause you to have higher risks and you want to be on particular medication. I mean, if you have a strong family history of cancer and you want to know if you carry a mutation, that's going to change your course of treatment if you carry a mutation. So, I mean, I don't know, you can pick one over the other.
Okay, thanks. Tough when there's both, and it's not like one is more prior than the other. They're both horrible, you know.
Right, well, right.
Great
Your
question.
risk might be different for one than the other. You might be more, you know, if you were to talk to a genetic counselor, they might say, oh, you know what, we're not concerned about X, Y, and Z with your family history of cardiovascular disease. Or you might find that a counselor in cancer would say, yeah, I'm not so worried about that, but I'm more worried about what you're telling me about your heart disease. So really be, you know, sitting down with someone to go over the family history that would probably be able to direct you the best way.
Okay, thank you.
Wonderful. Anyone else? Great questions, by the way.
Thank you so much for doing this tonight.
Oh goodness, yeah, Deb, thank you so much. And just so you guys know, again, Deb's number, if you won't have any questions, is on there. Also, my email is on there. So if you have any questions that you want me to maybe pass along or you need any other info, by all means, shoot me an email. And then I'm going to stop the recording in a second here. But if you guys are interested in any other Gilda's Club events, feel free to go to our website, gildasclubchicago.org. So thank you guys so much. If there's nothing else, I will let you guys go.
Can I ask one more question?
Sure.
Thank you both. So if my cancer uterine was sporadic and a pretty fast, like 1 year recurrence, does that, based on some of what you paired earlier, put me at a greater risk now of getting a secondary colon cancer? Not if it's not hereditary.
So colon and endometrial cancer go together when it's inherited with those Lynch syndrome genes. I don't know your family history, so I can't comment on whether you're at higher risk for colon cancer, but you wouldn't be at higher risk just because you have had endometrial cancer. You wouldn't be at higher risk for colon cancer unless there was a genetic component to that.
Okay, and so sorry, I'm going to ask one more question. Are you familiar, thank you, with the Genomic Initiative? I don't know if all hospitals are part of it. I'm at North Shore, and that's what they call it.
Yeah, so there are a lot of different initiatives. I think North Shore, I'm not familiar, but I think that they are doing like an initiative where primary care physicians are doing genetic testing on a panel that includes, I think, cardiovascular genes as well as cancer genes and maybe some pharmacogenetics as well. And they're doing something that way, sort of a healthy screen kind of a thing. And of course, the federal government is out doing like genomics and following patients for years and years and trying to figure things out. Christ Hospital has yet to do, they're not involved in anything like that. We've always thought and really wanted to, through our program, start like a healthy screen to do something similar where people have sort of a panel of genes associated with cancer and cardiovascular disease and also pharmacogenetics and get a pharmacist involved. So, pharmacogenetics is, basing mutations, those mutations based on what kind of drugs that you need to take for maybe depression or for anxiety or for those kinds of things. And so that's something that we're really wanting to look to do at Christ, but we haven't started that yet.
So if I would volunteer to participate in the genomic initiative, I'm not doing it, it's not going to help really me. I'm doing it for future cancer.
I think it's a component of both. I think it's a component that it helps the patient, but I also think it's a component that it gets data. You always want to have some data driven and to make some assumptions about things. So I think it's a dual thing.
And probably can't hurt me discrimination wise for insurance or anything.
I wouldn't think so.
Thank you.
Sure.
I want to wish everybody a good tomorrow.
You too.
Thank you. Same to you all. Thank you again, Deb. Have a wonderful rest of your evening, everybody, and hopefully we'll see you all soon.
Okay. Bye-bye.
Bye-bye.